Welcome to another episode of Prostate Cancer Prostatic Diseases podcast. I'm here with
Professor Zattoni, who will talk about PI-RADS-free lesions, which is an important topic nowadays. So please, Professor Zattoni, can you please start introducing yourself and tell us a little bit more about your study, please?
Good morning, everyone. Thank you for the opportunity to be here today with you. My name is Fabio Zattoni, and I'm assistant professor at the University of Padua, Italy. For the last 4 or 5 years, I have been part of the EAU-YAU academic urology prostate cancer working group. And during this time, my research has been focused on advancing technique in prostate biopsy, optimizing prostate cancer detection, and improving MRI quality. I like prostate cancer. I like especially detection of prostate cancer. This is why I decided to perform also this study. That is a retrospective study. We included across 10 tertiary referral centers, and we included 700 patients who had an initial positive MRI with a PI-RADS 3 or more than 3, but a negative MRI target and systematic biopsy. So consider that this is the biggest study ever done with such numbers with this inclusion criteria. And
Thank you for presenting your study. And how did you plan exactly the design of your study for the audience, for the ones that haven't read your manuscript yet?
Yeah, so we divide this group of patients in 3 groups. The group 1 had a repeat biopsy without a new MRI. Group 2 had a standardized second MRI and a repeat biopsy. And there is a third group that had an MRI and a biopsy targeted by clinical radiological factors during follow-up. We analyzed the detection rate of any prostate cancer and clinical significant prostate cancer, as well as a predictor of cancer detection was assessed with the multivariable analysis.
Okay, thank you very much. And what do you think these results may change the common clinical practice? Because as you know, now we still have a big problem with PI-RADS-free lesions and with negative MRI, particularly because a lot of people support the fact that these lesions probably, even if they're cancer, they are not significant cancer from a molecular point of view. So what are your thoughts about this?
So our findings highlight the importance of tailored follow-up strategies for these patients. We found varying rates of prostate cancer detection depending on the follow-up approach, which highest cancer-free survival in group 3 that had a triggered MRI and biopsy. This suggests that less aggressive monitor may miss clinical significance cancer, also in that category of PI-RADS 3 lesion. The predictors were identified with the PI-RADS score, of course, the age, prostate volume, and presence of ESAP can help guide with patient selection. In this patient, maybe a more intense follow-up and a repeat biopsy should be recommended.
Okay, I think that these findings are very important for going on in this area of research. And in your opinion, this is another important hot topic. Which kind of biopsy in terms of axis, fusion or cognitive, and how many cores do you think we should take ideally? I'm asking you in your opinion because, as a matter of fact, there is not an answer yet. So I'm not. I really think that it's more an opinion of you, something different from what I don't ask you to answer me by the literature because, as you know, there's a field. So I really want you to tell me how do you do it in your clinical practice? What's your preference? If you like spectral, if you like transperineal, if you like fusion, cognitive, what do you like the most?
My preference is the transperineal approach, while recent prospects show a significant statistical significant benefit of the transrectal route over the transperineal. I believe even a modest advantage in cancer detection favors using the transperineal access is present. Furthermore, there is an improved patient safety profile by avoiding the risk of severe sepsis associated with the transperineal compared to the transrectal. So this is why I still believe that transperineal is better. When we think of patient well-being, even in a small incremental benefit should be carefully considered. Regarding the fusion biopsy, we performed the software one. I agree that it may not provide a universal diagnostic benefit compared to the cognitive. However, for training purpose and optimal MRI ultrasound registration, especially for smaller lesions, I still believe a software can give some advantages. We think that we are training next generation of radiologists and urologists, so fusion software can help standardize and maximize the accuracy of targeted sampling. Regarding the ideal number of biopsy core, we perform 3 cores per lesion. We must balance the desire to sample suspicious areas and the risk of oversampling, the potential migration of cancers, stage migration and risk migration is still a problem, increasing the number of cores. So we can think also to personalize do a risk adapted strategy in terms of choosing the number of cores per lesion. However, I still see a problem in this, because then could be a problem of selecting the appropriate patient, and an extensive sampling can create problems in the patient the follow-up and the patient outcome that could be different according to the number of core taken. So my suggestion is to do 3 per lesions.
Let me ask you a question, but do you do transperineal without antibiotics, or to use antibiotics? And the second question, how do you manage pain? Do you do it actually in the ambulatory setting?
Yeah.
Or?
We start not doing antibiotics. Of course, the patient has not to have symptoms, and ideally we perform a urine culture before the biopsy. So yes, and the patient outcome that could be different according to the number of core taken. So my suggestion is to do 3 per lesions.
Let me ask you a question, but do you do transperineal without antibiotics, or to use antibiotics? And the second question, how do you manage pain? Do you do it actually in the ambulatory setting?
Yeah.
Or?
We start not doing antibiotics. Of course, the patient has not to have symptoms, and ideally we perform a urine culture before the biopsy. So yes, the aim is to avoid antibiotics. And regarding the pain, we perform a freehand transperineal biopsy. Local anesthesia is fine. We sometimes use some benzodiazepine to make all the procedure more comfortable. I think the main goal is to decrease as much as possible the duration of the procedure. More is the experience the surgeons, more the patient is in comfort, and so if the procedure take 5 minutes, I think is fine for the patient. If it takes half an hour, as the resident do, it could be a problem.
So, what is, in your opinion, the ideal number of procedures to train a resident? Because, well, in several authors support the fact that it's easier to learn a transrectal biopsy when compared to a transperineal biopsy, which in the freehand ways particularly, it might be challenging a little bit for young residents.
Yeah, I think the worst scenario is learning to do the transrectal and then shifting to the transperineal. If residents just has no choice and start doing the transperineal, I see them have a good results after 15-20 cases. So after that they start performing the procedure quite quickly and in a good way. I think after 50 you have the good skill, and after 100 you are like a master.
I completely agree with you. So tell me something, another important matter of debate in the actual panorama of prostate cancer biopsy. What do you think PET-PSMA will have? What impact will this technique have in the actual management of prostate biopsy? Do you see any future for this kind of imaging technique?
Yeah, while this study did not evaluate PET-PSMA imaging, some emerging data suggest it may have a complementary role to MRI for detecting prostate cancer, especially in cases with discordant MRI biopsy finding. Combining evidence imaging modalities could potentially improve the selection of patients requiring repeat biopsy in this clinical scenario. However, further research is still needed on the optimal integration of PET PSMA and MRI. While PET PSMA imaging may have a complementary role, the detection of prostate cancer, especially with discordant MRI finds, must be cautious, because we expose a patient to radiation even if they may have no cancer. Before considering PSMA PET in this particular group of patients, the one that I included in my study, would be firstly obtain a second high-quality MRI. Especially radiology should consider how lesions evolve during time. So apply a tool like the Precise score to evaluate how lesion changes over time. So before a PET PSMA, I would recommend a second MRI.
So in your experience, actually, what are the quality? What is your experience in the everyday clinical practice? So do you get good MRIs? Do you need to perform reviews with your radiologist, or is it the standard in your area? Good.
MRI quality remains a significant problem, especially when imaging is performed at not a specialized center by radiology lacking adequate experience. We frequently have to do a revision of the images. This, of course, helps takes time for us, for our radiologists, and is a very big problem. I think this is something that society should address and force to do MRI only in high volume, high quality centers. I think radiologists should be pushed in giving urologists key images, a precise indication of where the lesion is. Maybe giving the number of the sequence that there is the suspicious area. This will help urologists also in performing the fusion biopsy.
And do you think urologists should have MRI courses?
This is also a big problem. I think our society, the European society, is going to putting a lot of effort in doing courses and doing training for urologists. But of course, not all urologists that perform MRI has a real knowledge of MRI. So this is why I think also radiologists should make very clear where the lesion is, where we have to go for sampling the prostate.
Okay, so we'll get into the end of this very nice podcast. So, what are the gaps in the literature, in your opinion? What should researchers focus on in the next couple of years? What is your opinion?
So I'm telling you what I'm doing. We are conducting a prospective study, a randomized prospective study comparing the needle size during transperineal prostate biopsy. This, of course, is not possible with the transrectal because using a 16 gauge would be harmful for the rectum, but for the transperineal is possible. So we compare these two groups with 16, 18 gauge in order to show that a bigger needle can have a more precise access to the prostate, especially the biggest one, and take more sample size and more tissue. And this will also, in my mind, have important implications with the digitalization of the samples and with the use of AI for the prostate cancer detection. So this is my next work I'm doing regarding prostate biopsy, and I hope in the next future to be able to share with you our results.
Okay, so the last question. So how do you manage normally the problem of upgrading and downgrading we have on radical prostatectomy? Meaning that, do you think that your approach may lower this interesting research you're proposing will lower this risk?
This is an important point. There is evidence that the targeted biopsy increased the downgrading than the radical prostatectomy. It's still a big problem of targeting biopsy, and this is the next challenge for urologists. We do not have a clear follow-up of these patients, and we have to create one. Years ago, everyone were doing the systematic biopsy, and for the patient had a similar follow-up. Now everyone is doing the biopsy in their way, with their number, with their technique, and so I think this will impact a lot with the patient follow-up. I hope also with my study we can generate more evidence of which needle is better. So maybe in the next future, at least for the needle size, we will have a standardized dimension to be suggested in the clinical.
Well, I truly agree, because this is something that already in breast cancer is done. Probably we don't have good biopsy, also doing genetic testing and these kind of tests, probably we're not getting enough tissue. So I'll give you the word to conclude on your study, and then I will thank the audience, because I think that we went through all the real problems of prostate biopsies today. So please, Professor Zattoni, I give you the conclusions. So the stage is on you.
So thank you very much for this opportunity. I think our study is important because we show that a patient that has a negative biopsy after a first positive MRI should be taken into care and have the straight follow-up, at least as an active surveillance protocol, and repeat an MRI in 1 year. And if the lesion still is present, if the PSA is still high, you should perform again a new prostate biopsy. So this is my suggestion.
Okay, thank you very much. So this was episode 11 of Prostate Cancer Prostatic Diseases podcast. I thank again Professor Zattoni for giving us this very interesting talk, and I thank all the audience of prostate cancer prosthetic podcast for tuning in. And I say bye to everyone. Thank you.